So chapter 15 is basically about the pathways inside the brain. And as we mentioned before, any reflex or any pathway through the brain can be afferent or efferent. And afferent is going toward the central nervous system, and the efferent is leaving the central nervous system. And we always start with receptors, sensory neuron, that's called the afferent, and the sensory pathway inside. And then you have a nucleus, motor tract, and motor neuron. This is how it goes with afferent or efferent. Sensations, or the types of senses. We talked about the special senses before. We talked about the brain. And how many special senses do we have? 5. What are the 5?
Smell, taste, hearing,
Seeing. And the 5th one? Balance. Yes. Anything else is general senses. Okay? Just remember the special senses, and anything else will be the general senses. Temperature is a general senses. Pain, touch, pressure, vibration, proprioception. So everything else is basically general sensation. And there is a difference between sensation and proprioception and perception. Sensation is just the actual arrival of the sensation or the information to the central nervous system. Just the sensation arrived, like electrical signal reached the brain or the central nervous system. Perception is your awareness, that you understand what you're sensing, what you're hearing, what you're seeing, and so on. So these are 2 different terms. And as you just said, and always remember there are 2 names for each one of these sensations. Olfaction is the same as smell. Vision means sight. Gustation means taste, and we tend to forget this one specifically. Gestation or gustation, it means taste. And equilibrium or balance is the same, and this is the one that we usually forget. We always remember olfaction. We can hear, we can smell, we can see, we can taste. Usually those 4 everybody remember, but the 5th one is balance or equilibrium. It's the same thing. So these are the 5 special senses. We start the sensation with the receptors. So special sensation start with the special sensory receptors. General sensation start with general sensory receptors. And obviously the receptors for the special senses will be located within the organs. So special sensory receptors of the eye are within the eye. Special sensory receptors of the hearing are within the inner ear, and so on. For each one of these receptors, will have a specific or a specific sensitivity. Some of them are very sensitive, some of them are less sensitive. And the receptive field is the area that's monitored by one of these receptors. Like I ask one of you to monitor this area. You are receptor number 1, and this is all what you're looking for. This is your receptive field. And I ask somebody else to monitor this area. You are receptor number 2, and this is your receptive area, and this is number 3, for example. So this is your receptive area. If I ask one of you to monitor the whole class is your receptive area, but you will be less specific, right? So the smaller the receptive area, the more specific you are, right? So if I'm asking you to monitor this part only, anything that happened in this part, you will easily monitor it. But if I'm asking you to monitor everything, by the time you look like this, maybe something happened here, you didn't see it, right? So it's more accurate when it is smaller receptive field. The smaller the field, the more accurate. So basically, if I'm looking somewhere and I hear sound, and you tell me where is it coming from, probably this area. That's not very specific, right? Because I'm monitoring a big receptive area. But if I'm looking at this part only, which is smaller, and you tell me where is it coming from, it's coming from this table, specifically, from this part, right? So you can specify if the receptive area is small. So these are like, these are the receptor, one of the receptors, and this is receptive area. Here is another receptive area. If it is smaller, if it is like this, just tiny like this, it will be more accurate, and you can localize more. If it is larger, less accurate, less localization. The stimulus itself that stimulate the receptor, or that is picked up by the receptor, can be in the form of physical force, dissolved gases, chemicals, sound or light. Physical force is like pressure, okay, like when I touch you, when I pressure you, okay? And in this case, the receptor will be like a balloon, okay? If the balloon is spherical shaped, and when you compress it, the shape is going to change, right? If you squeeze it or if you press it, the shape will, instead of spherical, it will become more flat. So you're disrupting the normal shape of the receptor by pressure. And this is like pressure or touch. Dissolved gases, this is like the taste sensation. Anything that you eat, you taste it. How do you taste it? There are dissolved chemicals that actually travel and goes inside your taste buds, stimulating the receptors in a chemical way. Same thing when you smell something. How do you smell? When you smell something, there should be a chemical compound, okay, that's in the air and goes to the receptor of your nose, react with the receptors, stimulate them chemically. And this is called the chemical sound that's going to stimulate the hearing receptors, and the light is what stimulate the vision receptors, so the light receptors. Adaptation means reduction of the sensitivity of constant stimulus, which means if you are wearing your glasses all the time, sometimes you even forget, right? Are you wearing your glasses? Yes, right? Don't you do that sometimes? If you're wearing a hat all the time. Sometimes if I ask you all of a sudden, are you wearing your hat? Let me see. Yeah. You forgot, right? Why? Because it is constant and painless stimulus, right? You wear your watch all the time. Some people leave it the whole day long, and sometimes you tend to forget. So you get adapted. This is adaptation. So what's adaptation? Reduction of sensitivity. And you have to have two things to be able to adapt. Number one, constant. Meaning, if you wear it and remove it, wear it, remove it, wear it, remove it, you will not forget. But if you leave it on for the whole day long, which is constant, and if it is painless, of course, I can't get something hot and I touch you and I say, get adapted to it. Forget about it. Can you forget? Of course not. If it is painful, you cannot forget, even if I leave it for more time, for a long time. So it has to be constant, painless for adaptation to occur. And the receptor for this case are called the tonic receptors. And these are active and slowly adapting. So it takes, for these receptors, it takes some time to get adapted. And the reason why it's slowly adapting is because it wanted to remind you with the stimulus, except if it is constant and painless. Phasic receptors, these are the fast adapting for something that's not painful. So when you stimulate the receptors, whether you are stimulating the receptors physically, chemically, by light, whatever the stimulation is, all of them will end up producing action potential, which is the chemical signal that start from the receptor and go the way that we talked about before several times. So it will be generated in the receptors, go from the receptor to the afferent, right? Ganglia, enter, and go to the dorsal horn, right? Something is happening inside depending on what type of sensation, and then it's going to exit through the ventral horn, efferent, effector. Do you remember this basic structure of any sensation? So the electrical signal, which is called the action potential, start at the receptor and travel the normal pathway with some changes or some differences that we will talk about. And the action potential will not only tell you about the nature of the stimulus, it will tell you about the magnitude, the amplitude, the strength, the duration. So you know that something touch you, it's painful, very painful, less painful, it stayed for 1 second, it stayed for 5 seconds. So all of that will generate different action potentials, right? When I touch you with something that's a little bit painful, action potential will be generated. If I touch you with something that's more painful, another action potential will be generated that's larger. So the action potential will always reflect the duration and the intensity and the nature of the stimulus. Receptors in our body, if the receptor is catching up or receiving from something outside of the body, you call it exteroceptors. If it is getting something from inside, like anything happening within your body, you call it interoceptors. So either you're picking up a signal from outside or from inside. Exteroceptors, interoceptors, and the third one that you might think about it as internal or interoceptors because it's inside your body, but they like to classify it differently because it's doing something that's completely different. So receptors receiving signals from outside the body, exteroceptors. Receptors picking up signal from inside, interoceptors. The third one is called proprioceptors. And these are receptors, special type of receptors. You might think about it as internal, but they classify a special classification. And this will tell you the position of your joints and skeletal muscles. Okay? Like if you're closing your eyes, okay, and this is 90 degree, right? This is an obtuse angle. This is an acute angle. Flexion, extension. Can you tell? I'm contracting my muscle. I'm relaxing my muscle. Can you tell without seeing? How did you pick up this? Proprioceptors. These are the receptors for proprioception. Proprioception. So what's a proprioception? It is the sensation of position of joints and skeletal muscles. Okay? And this is a special sensation. It's not exterior, not interior. Are we following so far? Any question?
So what would be an example of interoceptors?
Anything inside, like it's something in the intestine, something in the pain in the
So
kidney.
like smooth muscle organs?
Anything inside, yeah.
Okay.
Distension, maybe anything inside that will be called interoceptors. Something that's picking up signal from inside. Intestine, heart, anything. And not necessarily smooth muscles. It can be a pain that's irritating a nerve inside. So heartburn, heart pain, stomach colics, anything like that. Anything from inside, it's called interoceptors. Anything from outside that's picking up an external stimulus, that will be exteroceptors. So proprioceptors. Proprioceptors will basically tell you again skeletal muscles and joints. Of course, we don't have proprioception for the visceral organs. Can you tell me where is your liver? Do you feel it? Do you sense it? Or just because if you told me my liver is here, Do you know that your liver is here because you feel it and you know it's here, or because you know anatomy? Right? Just because you know. If I ask somebody else who have no idea about anatomy, would he know where is his liver? No. So there is no proprioception of the visceral organs. And always, when we say visceral, anything inside this. Anything inside your trunk is visceral. So you cannot feel your viscera. Actually, there are some times, and I remember seeing that in my internal medicine round, and I was actually taking a test, and I was using the stethoscope to get to hear the heart. I couldn't hear it. So like this, okay, I can't feel the tricuspid area or the pulmonary area. I can't hear it. There's something wrong happening. You do the percussion, I can't feel it. So I talked to my professor, and he said, yes, do exactly the opposite of what you're doing. So instead of here, make it here. Instead of doing this, you do it this way. And when I started to feel the liver, he said, no, the liver is the other side. This was a condition that's called dextrocardia. It's an abnormal condition. You don't have to know that, just something interesting that I remember. And the dextrocardia is everything reversed inside the body, and the person didn't even know. Like your liver is here, right? It's here. The spleen should be here. It's here. Everything is a mirror image. Everything was reversed. So the only way to get to know about the liver is left. Spleen, try to feel the spleen. Take a deep breath and start to feel it. Spleen is actually right side. This is called dextrocardia, and I'm giving this example to tell you that he's been living with this his entire life, and he didn't even know that everything is reversed. Everything is the other way around. So if he can feel, he will say, my liver is here, right? No proprioception for visceral organs. Receptors for pain are called nociceptors, and you need to remember that. Receptors for temperature are called thermoreceptors. Receptors for physical distortion is called mechano, and for chemical is called chemo. Okay, so I would say thermo makes sense, mechano makes sense, chemo makes sense. Nociceptors, just remember it, it's for pain. Nociceptors for pain. So this is the name of the receptors depending on the nature of the stimulus. So nociceptors are for pain sensation, and it is usually in the superficial parts of the organs, and the part that's heavily innervated is the periostea. What's the periostea? The outer layer of the bone. Yes, and that's why if you have a problem in your bone, you feel severe pain, right? And it stays for a long time because the cover of the bone is heavily innervated. And that's why if you have a head or something in your bone, you feel like terrible type of pain. Why? Because it's heavily innervated. A lot of nociceptors in the periosteum. Temperature, on the other hand, can also stimulate the pain receptors. But you said temperature is thermoreceptors, right? Didn't we say that? Temperature is thermo. Pain is noci. No, sometimes thermo, and I mean the temperature can sometimes stimulate pain receptors if it is extreme. Like if you feel something, you can say, it's warm, it's cold, right? This is thermo. But if it is ice, and I touch you to the extent of being painful, that's stimulating the nociceptors. Or if I touch you something that's not warm, it's hot, painful, it will stimulate the nociceptors. So the point here is the extremes of temperature does not only stimulate the thermoreceptors, they also stimulate the nociceptors. The nature of the nociceptors are called free nerve endings, and the receptive area is large. That's why usually when you feel pain, most of the time it's not very specific. You say like, I have pain in this area, right? Most of the time. Where? Like around here. Yes, can you point out to it? No, it's just in this area. Most of the time, until you have a specification of the pain for other reasons, but most of the time, because it is monitoring a large area, large receptive area, so it's not very specific. It's free nerve endings. And in this case, the type of axon can be type A and type C. Do you remember the types of axons? Which one is the largest and fastest? A. And which one is the poorest or the slowest? C. Do you use A or do you use C? Sometimes we use A, sometimes we use C, depending on the nature of the pain. What type of pain are you talking about? If this is a sharp pain, like a cut pain, something that's piercing your skin, something that's destructive to your body, this is something urgent. This is an urgent type of pain that you have to be aware of immediately to take an action, so we use type A. But think about this. If you're having a knee pain for the last 5 months, is it something urgent? Is this something urgent that you should be alerted and take care of it right away? You have this for 5 months or even 5 days, right? So is it urgent? It's not urgent. So what type of sensory neurons do we use? Type C. We're not even worried about it. If it's delayed, to know that you're having some need or some like low type of pain in your abdomen, for example. There is nothing urgent. But how about the heart pain? You're having angina. Type A. This is an important type of pain that you have to take care of it right away. If you step on something, that will give you severe pain immediately. What type of receptors do you use in this case? Type A. So type A for sharp, more important pain. Type C is for, they call it the dull, aching pain. Dull, like some pain that's always there and it's not urgent. We use type C. Type A, of course, is myelinated, and this is the fastest. And type C is unmyelinated, and this is the slowest. Type A will go to the primary sensory cortex. Why? Primary sensory cortex. The most important thing to remember about the primary, and where is the location first? Primary sensory cortex. Where is it located in your cortex? In which gyrus? Pre-central?
No, post-central.
Post-central? Pre-central or post-central?
Post-central.
Post-central. What's the pre-central?
Pre-central is the motor.
Yes. Pre-central is the primary motor area. Post-central is the primary sensory area. Primary sensory area is the area of sensation or of the primary sensation that you have to be aware of. Anything that reaches your primary sensory cortex, you will be aware of it. Do you mean that sometimes the pain we are not aware of? Yeah. What if you fall asleep? Do you feel your knee pain? Do you feel your knee pain while you're sleeping? If you're having arthritis, for example, like older people having arthritis for the past couple of years, you don't fall asleep at all? Like feeling the pain the whole night? No, you fall asleep and everything is fine. And when you wake up, you start to feel it again, right? So obviously, that does not go to the primary sensory cortex. Otherwise, you will be aware of it. Where does it stop then? It goes to the thalamus. If you still remember, we talked about each part and what each part is doing, or what's the function of each part of the brain. And in this case, we talked about the thalamus as being the secretary of the brain. Do you remember that? The sensation go, from receptor to the afferent, go to the central nervous system, goes up, goes to the thalamus, and the thalamus will sort it out. This is like the secretary. You go to the secretary, yes, how can I help you? I need an application. Here is your application. Do you see the manager just because you wanted an application? If you go to any company or office or something, do you always see the manager just for something minor like what are your working days? What time do you close today? This is something that does not need the attention of the manager, right? So you go to the secretary, I need an application, here's your application. And the manager doesn't even know about it, right? But I'm coming for an interview and I have to see this is something urgent matter. I need to see the manager. Yes, just give me a minute, go to the manager. Somebody wanted to see you if it is something important. So the thalamus is the secretary of the brain. Anything goes to the thalamus will sort it out and say, okay, this is not something urgent, this is not something important, I will take care of it. This is something important, I will send it up to the primary sensory cortex. Are we following? This is exactly what happened. So if this is a dull aching pain, if this is something, just a little bit of irritating pain, chronic pain, it go to the thalamus, and the thalamus will shield it. The thalamus will just stop it. It will not send it to the primary sensory cortex because you cannot be busy 24 hours a day for years just because something that's not going anywhere, right? But if this is something that's urgent, sharp pain, you have to be aware of it, so it has to reach the manager, which is the primary sensory cortex, because it needs your attention. If something is, you're touching something hot, you have to remove your hand right away, and you have to be aware of it if it is painful or sharp pain. Type C, on the other hand, will carry the slow pain. This is something aching, something burning. It's not sharp pain. So sharp pain, go to A. Okay, burning or aching pain will go to C, through C. And it will end up at the thalamus, and you will not be aware of it until something changed. Normally, under normal circumstances, you can suppress it, you can be aware of it depending on the situation. Like if you're sleeping, you're not aware of it. If you're awake, you can feel it a little bit, but you can suppress it and forget about it. So you are a little bit aware of it because it goes to the thalamus, which is part of the central nervous system, but it doesn't go to the primary sensory area. Thermoreceptors. Thermoreceptors are temperature receptors. It's also free nerve endings. So what was the pain receptors? What's the name for the pain receptors? Nociceptors. And it is free nerve ending. We know what's free nerve ending, right? This is the receptor. This is one type of receptor. And this is the pain and temperature receptor. Free nerve endings. Like this. So the receptors looks like this. Normal receptor will be like this. So it's also free nerve endings. And it is located in different parts that you need to know about the temperature of this part. So it's in the derms. You know if it is hot, if it is cold outside. Skeletal muscles, so you know when to stop and when to start. Liver to react by metabolism. Hypothalamus, because of the presence of what? What is located in the hypothalamus, and it has to pick up the signal. The thermoreceptor in the hypothalamus, we talked about this. Do you remember the thermostat that we talked about in the hypothalamus that's adjusting your body temperature? What is your body temperature right now? Around? About 98.6. Which point exactly of your central nervous system is keeping this at 98.6? It's the hypothalamus, yes. You know when you change the thermostat in your house, like I want it on 70, right? You set it on 70 and your air conditioning unit, the furnace and the heating unit will keep it at that, right? Where did you do that? In the thermostat. Where is the thermostat in our body? Inside the hypothalamus. Okay? So the hypothalamus also has to be aware and continuously getting an input of your body temperature in order to adjust it. Goes up, it will lower it down. Goes down, it will bring it back up. Temperature doesn't only go to the reticular formation and thalamus, like the pain go to the reticular formation and thalamus, but temperature go to the reticular formation and thalamus and partially to the primary sensory cortex. So you are aware of it, and that's why I feel cold, I feel hot, I feel it's warm, right? You feel it. So it goes to the primary sensory area. The next type is the mechanoreceptors, and this is stimulated by distortion of the plasma membrane. Something like this, okay? And when you touch it, or when you pressure, okay, the shape will change like this, right? Like you're pushing on a balloon, it's going to distort the shape, and you're distorting the inside, or distorting the plasma membrane, changing the shape, and this is how the stimulus affect the receptor. So it's usually compression, like if I'm touching you like this. That's a mechanoreceptors. You're changing. Imagine the mechanoreceptors like a balloon. Okay? So you can press the balloon. You can stretch the balloon. Twisting, when you twist something like this, you're still going to change the shape of the balloon, right? You can twist, you can compress, you can stretch. So these are the types of sensation that stimulate the mechanoreceptors. Does it make sense? You're having a balloon, receptors that looks like a balloon. You can compress the balloon, changing the shape, distorting the shape of the membrane. You can twist, still mechano. You change the shape by twisting. You can inflate more, right? Stretch. Any one of these will change the shape of the plasma membrane, and this is going to open some channels. We don't have to go through the details, but when you distort the membrane like this, channels will open and ions get in and out, and electrical signal or action potential will be generated. Okay? Mechanoreceptors can be tactile or tactile receptors, and tactile means touch. Tactation, tactile receptors. So this is touch, pressure, vibration. And touch can be fine touch or crude touch. What's the difference between fine touch and crude touch? If I touch you with like a pen, okay, this is fine touch. If I touch you, you can tell me exactly, right? If I touch you with like a pen or something, a pencil, like this, tell me exactly where it is. You tell me it's right here, right? Can you tell? You can. But if I get like a piece of cotton or something, piece of cotton that's really big, and touch you, where is it? Here. Yeah, can you point out to it exactly? No, it's around this area. You cannot like pinpoint to it, right? This is called the crude touch. So there is fine touch and crude touch. Plus pressure and vibration, all of that work through the tactile receptors. The next receptors, the baroreceptors. And these receptors are basically inside our viscera. And usually they work by stretch. Okay, or depending on which type we're talking about, but it is inside our viscera. Urinary tract, reproductive, digestive, all our viscera inside. Proprioceptors also are mechanoreceptors, and these are to pick up what? Proprioceptors pick up what type of sensation?
Joints, muscles, joints.
Yeah, joint and muscle what? Position. Position of the joint and muscle. Position of joint and muscle. These are the proprioception. Okay? Tactile receptors can be one out of these receptors. If you remember the name, that's good enough. Prenerve ending, root hair plexus, tactile receptors, tactile corpuscles. The tactile discs are called Merkel discs. Tactile corpuscles are called Messner corpuscles. Laminated corpuscles or Pacinian corpuscles, Ruffino corpuscles. These are the different types of tactile receptors. The next type is the baroreceptors, and again, this is in the wall of the visceral organs. Blood vessels, digestive tract, urinary tract, reproductive system, and so on. Proprioceptions in the joint and muscles. Oops. Fine touch and pressure, mechanoreceptors. And one more time, you have fine touch and you have crude touch. You have fine pressure and you have crude pressure. Crude means vague. Okay, so if I'm touching you like this, okay, you can't tell exactly where I'm pressing you. But if I did that with my finger, that will be the fine pressure. Same thing for the touch and pressure. It apply for both of them. So this is sensitive, and you can tell exactly the location and even the shape and texture. You can tell exactly the details of the stimulus, while crude, whether touch or pressure, you give just general information about it. It's poorly localized. So tactile receptors can be free nerve endings like these, root hair plexus in the root of the hair, like these. Miracle desk, fine touch and pressure. Corpuscles or Meissner corpuscles, fine touch and pressure also, fast adapting. And it's located around the fine areas. The tactile corpuscles or Meissner corpuscles are located, so location here, something that we need to know, it's located more in the fine areas of the body, like the eyelid, the lips, the fingertips, the nipples, the external genitalia. So this is all contain the tactile corpuscles, which is this type of tactile receptors or touch receptors that detect the fine type of touch. So these are the tactile corpuscles or Meissner's corpuscles. So where is it located and what does it touch? And it is also fast adapting. Laminated corpuscles or Pacinian corpuscles, this is for deep pressure. Ruffini corpuscles, this is for pressure or distortion of the skin. So anything happening, distortion of your skin, will be picked up by Ruffini corpuscles. Baroreceptors. What's baro means? Baro means pressure. Baroreceptors, pressure receptors. And this is something that detects the pressure. Do you remember when we talked about this? This is the aortic arch, brachiocephalic trunk. You know this? This is the common carotid artery. This is the common carotid artery. Give you internal and external. And these receptors are located here. Remember those? The carotid sinus and aortic sinus. When the blood pressure increase, it's higher than normal. So more blood under more pressure, leaving the heart, going to this area, stretching it, going to this area, stretching it. To those two areas, when they get stretched, it means the blood pressure is increasing. And they are going to send the signal to the heart to slow down. Okay? They send a signal to the central nervous system and go to the heart to slow down. And these are called the baroreceptors. Do you remember the baroreceptors and chemoreceptors or not? These receptors again are located around the aorta, around the bifurcation of the common carotid artery to internal and external, and it picks up the change in the pressure, in the blood pressure. If the blood pressure increases, it will be stretched. So when they are stretched, they send the signal to your brain that the blood pressure is going up, do something. And this will send, the brain will send the signal to the heart, slow down. The blood pressure is increasing, slow down. Dilate the blood vessels, lower down the blood pressure somehow. Proprioceptors, again, this is located in the muscles and joints, and they also pick up the tendon and ligament tension. So it tells you basically, are you flexing or extending your joint? I'm flexing, I'm extending. How did you know? Proprioceptors inside. This is what tells me. I am contracting, I'm relaxing, contracting, relaxing. Same receptors. And then if somebody's like twisting your arm or something, or you're overstretching like this, the tendon that's stretched will have the same receptors, and it will send you a signal to tell you that there is a tension on the tendons or ligaments. Proprioceptors can be muscle spindles, Golgi tendon organs, and receptors in the capsule. These are the receptors of proprioception. Chemoreceptors is the next type of receptors, and actually it's located in the same spots of the mechanoreceptors. Okay? And they pick up the change in the chemistry of the blood. Change chemistry of the blood. What's the change chemistry of the blood? Like oxygen goes down. This change in the chemistry. Carbon dioxide goes up. pH change. Carbon dioxide, if it increase, to react with water to make what? Carbon dioxide with water? Huh? Anybody? Do you know the fountain machine? Do you know how the fountain machine works?
Oh, you mean the carbon in it that makes the pop?
Yes.
Yeah.
The soda?
Yeah.
How? If you look at the fountain machine, look in the back, you see like pipes, right, going in and out. What are these? This is basically inside this machine, the soda machine or the fountain machine. Inside of this, there is water, a tube bringing water or a pipe bringing water, just water, distilled water coming in. And another one is bringing whatever it is, Coke or material that make the taste. And the third one is what I'm talking about now. The third pipe will be for carbon dioxide under pressure. So carbon dioxide is going down the pipes under pressure, and when the carbon dioxide reaches the water under pressure, it will react and making carbonic acid. Carbonic acid. And this is where the name carbonated beverages came from. We hear that, right? Carbonated beverages. What do you mean carbonated? Carbonic acid. And this is actually what you feel like what happened when you leave your Pepsi for a couple of hours. You throw it away, right? You don't use it anymore. Why? It doesn't taste good. Why it doesn't taste good? The carbonic acid is gone. And this is what gives you that taste or that sensation that when you open it and drink it, you feel it's good, right? Fresh. It's not, you didn't leave it for some time. When you leave it for some time, carbonic acid will be dissolved and return back to carbon dioxide and water again. And it just tastes like sweetened water or something, like water with some color, right? It doesn't taste like soda anymore. So chemoreceptors, these are the receptors that pick up change in the chemistry of the blood. What's the chemistry of the blood? Oxygen, carbon dioxide, pH. When you have a lot of carbonic acid, does that change to acidity or alkalinity? Increase carbonic acid. Acidity. You're adding acid. So you tend to get to acidity. So the pH goes up or down? Down. So what are the chemoreceptors picking? CO2. If it increase, oxygen. If it decrease, and pH. This is what is picked up by the chemoreceptors. So they pick up the change in the chemistry of the blood. And they, again, chemoreceptors and baroreceptors, both of them are located in the carotid and the aortic. So it's right here in the aorta, and right here to the carotid artery. And there is aortic body and aortic sinus, carotid body, carotid sinus. The carotid body, this is for chemoreceptors. And this is a carotid body. Carotid sinus is for increased blood pressure. Aortic and carotid, sorry. Okay? Did you get this? Around the aorta, around the carotid artery, there are collection of nerves in this area. These nerves are called aortic and carotid body that pick up the chemistry. Aortic and carotid sinus that pick up the blood pressure. What do you mean by chemistry? pH, oxygen, carbon dioxide. Are we following so far? Any question? Is it too early, or you guys understand everything? Too easy, or too hard, or too early? Too early? Okay. I guess I cannot change that, so. Okay, so chemoreceptors and mechanoreceptors again, both of them are located at the aortic arch and the carotid bifurcation. The bodies, the carotid body, or the carotid bodies, carotid and aortic bodies, they pick up the chemistry. Carotid and aortic sinus pick up the blood pressure, okay, which is the mechanoreceptors. When you say chemistry, what do you mean? You mean oxygen, carbon dioxide, and pH. So all of this was more of outside of the central nervous system. When you enter the central nervous system, there are three levels. So I want you to imagine your central nervous system is like a corporate office or a corporate building with three levels. So you can go up the elevator and you can go down the elevator, and this is the cortex on the top level. Okay, so for any sensation to enter, it usually go up first order, second order, third order neuron. It goes from level to level to level. First order, second order, and third order neuron. So the first order neuron is in the dorsal root ganglia, or the ganglia of the cranial nerves, like this. This is a receptor. This is the afferent. So it's located here in the ganglia. This is the first order neuron. Second order neuron can be in the spinal cord or the brain stem. So this is the first. This is the second in the brain stem or in the spinal cord. Which is inside the central nervous system. And the third one is in the thalamus. So it goes like this. I'm having some important information. Okay? You go to the corporate office, you go to the first level. I'm having this information. Okay, thank you, let me take it. I'm going to the next level and give it to the next person. Take a look at this type of sensation that we have. Okay, let me take it. I'm going to take it to the third level. Okay? And the third level is like the vice president, which will determine, or the secretary, whatever you want to call it. And this is what determines if you send it up to the cortex or not. So you go through 3 levels in order to reach the manager, which is your cerebral cortex. The highest of all. This is the highest. This is your voluntary work. This is how you think. This is how you analyze. This is how you determine what you need to know. Cerebral cortex is the top management of everything. So in order to reach the cortex, you have to go through 3 levels. You go with the elevator from the first to the second, which is in the brainstem, or the spinal cord, and then you go to the third, which is the thalamus, and the third will determine. If that's important, go up to the manager. If it's not important, you're going to stay here. 3 orders in order to bring sensation up. Are we following so far? Okay, so where is the location of these elevators? Do you remember this? And I think you did that in the lab. Do you remember this? What is this? Which horn? Dorsal horn. And this?
Ventral horn.
Lateral horn, okay. And this is? White matter. White matter. Okay, and this was which column? Dorsal column, and this? Yes. So posterior column pathway, which is this. There is an elevator here, goes up and down, and other elevators in other areas. These elevators are posterior column. You go from the back elevator, the elevator in the back of the building, for example, versus spinothalamic and spinocerebellar pathway, and this actually makes sense if you think about it. The posterior column, you can't say the name makes sense, but we will talk about it. But if you talk about the spinothalamic pathway, what spino means? Spine, spinal cord in this case, thalamic. So this is an elevator or a pathway that connects the spinal cord to the thalamus, right? Right? If you're going up, where are you going? Like you enter the building. I have this information. Where do you want to go? I want to go to the thalamus. Take the spinothalamic elevator, the spinothalamic pathway. Okay? Another sensation. I'm bringing sensation about balance, position, movement. Okay, so you need to go. Where do you want to go? I need to go to the cerebellum, being responsible for this. Do you remember that or not? That was the core of the last chapter. I told you. You have to know the function of the cerebellum, thalamus, hypothalamus, brainstem. Every part, there is a basic thing. What was the most important thing about the cerebellum? B, P, M. Do you remember this? Of course not. Right? Yes. Balance, position, movement. What is this? It's a function of what? Cerebellum. Yes. This is a function of the cerebellum. So if you are bringing one of these, you're going to the corporate office. I'm bringing these sensations. What kind of sensation are you bringing? I'm bringing balance, position, and movement. So do you want it to go to the cerebellum? Yes. Take this elevator that goes up to the cerebellum, which is spinocerebellar pathway. So you can figure out what type of sensation if you know the name. spinocerebellar. So is it going up or down first? Is this elevator going up or down?
Down.
Spinocerebellar. Which one is up and which one is down?
Down.
Is the cerebellum above the spinal cord or under? Above. So when you say spinocerebellar, you're going up. Does it make sense?
Yeah.
What if I said cerebellospinal?
Down.
Down, okay? So this is going up, right? Is it carrying sensation or motor command?
Motor. Sensation.
You're going up. You're bringing information to the management. You're going down. You're bringing orders, right? Can the manager give you information, or you give the manager information, and the manager give you orders? Is that right? If you're working somewhere, you tell the manager what's going on, you give him information, and the manager give you orders what to do, right? The manager is up. So if you're spinocerebellar, the manager here is the cerebellum, spinocerebellar. Are you carrying information to the manager, or are you giving orders to the manager? If you give orders to the manager, he will fire you, right? You get sensation, you bring sensation to the manager. So obviously anything going up to the management up, this is sensation. Anything that's going down, motor command. Are we following? Okay, so any one of those will be carrying sensation. What type of sensation? Tell me the name, I tell you the sensation. Spinocerebellar. What type of sensation? BPM. Thalamus, spinothalamic. This will be something related to pain. Thalamus is the thalamus receives a lot of things, but the most important is pain. So what are you bringing here? I'm bringing pain. So you're going to the thalamus? Yes. Take the spinothalamic elevator or spinothalamic pathway. Okay? So where is the location? Here it is. This is the posterior column. These are the spinocerebellar, and these are the spinothalamic. The green spinothalamic elevators, you have 2 elevators here. The yellow, you have 2 elevators, spinocerebellar, and the blue, also 2 elevators, and this is a posterior column pathway. So you have 3 types of elevators: the blue elevator, the yellow elevator, and the green elevator. Okay, each one of those will carry something, and it is going up. This table will summarize what you need to know about this. What's the posterior column carrying? The posterior column has 2 elevators that are called fasciculus gracilis and fasciculus cuneatus, and these will carry basically the same thing, but proprioception and fine touch, pressure and vibration from the lower half of the body, while the cuneatus will be the upper half of the body. So if you go back to this, you see those 2 blue? This is the posterior column going up. What kind of sensation are you carrying? Fine touch, pressure, and vibration. Are you bringing it from the upper half of the body or the lower half of the body? If it is the upper half, that will be gracilis. The cuneatus. If it is from the lower half, it will be gracilis. Okay, look at this here. So, what's carried in this elevator or column here? If you're following, what's carried here? Fine touch, pressure, vibration. From which part? Lower half. Yes. And this? Yes. Are we following? Okay. The next part is spinothalamic. Obviously, this is going from the spinal cord to the thalamus. We have lateral and we have anterior. Those carry 2 different things. So from the posterior column, they carry the same thing, but just different parts. For the lateral, it carry pain and temperature, and for the anterior, carry crude touch and pressure. Okay? So these are the two different functions, and this is all going to the thalamus. So what goes to the thalamus? Pain, which is the most important, pain. If you're carrying pain, you're going to the thalamus. Show me what you're carrying. Pain, go up to the thalamus. Plus crude touch, not the fine touch. The fine touch goes up all the way to the cortex, which is the posterior column. Okay? If I wanted to give a name, but this is not true, just for you to understand. If I wanted to give a name to the posterior column, I would call it spinocortical, because it goes from the spinal cord to the cortex. Okay? They didn't think about it this way. They just wanted to say, let's just call it a posterior column. But if that will help you to remember, but it's not, scientifically it's not true, but you can call it spinocortical. So where does it start?
Spine.
From the spinal cord to the cortex. What kind of sensation are you carrying? Proprioception, fine touch, pressure, temperature. Pressure and vibration, sorry. Okay? How about this? You're carrying pain, temperature, crude touch, not fine, crude touch and pressure. Where are you sending this information? Who is interested to know these types of information? Thalamus. So the thalamus is waiting for you to give him what type of information? Pain, temperature, and crude. Crude. How about the fine? No. The fine goes up to the cortex. Are we following? Spinocerebellar, of course, it will carry proprioception or any one of these three. One more time. Posterior column. Going up to, what's the destination? Is it going up or down?
Up
Up. Going up to what?
to the cerebellum.
No, you can call it spinocortical if that's going to help you. Spinocortical, from the spinal cord to the cortex. What is the cortex waiting for you to tell him? Or what kind of information is important for the cortex? Fine, yes. The fine things. Fine touch, fine pressure, fine vibration, proprioception. These are the types of sensation that the cortex is waiting for. What type of sensation is the thalamus waiting for? Crude touch, pressure, and pain. Yes, pain. Pain, temperature, crude touch, and pressure. What type of information is your cerebellum waiting for? Balance, position, movement. So you're entering the building. Security will ask you, what are you here for? What type of information are you carrying? I'm carrying balance, pressure, movement. Oh, so you wanted to go to the cerebellum? Obviously, because you're carrying this, because this is the cerebellum is waiting for you, because you're bringing this information. So go up using this elevator, spinocerebellar. If you're carrying pain, crude things, so obviously you're targeting to the thalamus. If you're carrying fine touch, pressure, and proprioception, you're probably targeting the cortex. Use the elevator at the posterior column. Are we following so far? This is the most important thing in this part to know. And it will follow first order, second order, third order. All of them will do the same thing. And most important of those is third order. Okay? Which part are you going to? I'm going to the cortex. What's your third order neuron? All of them are the thalamus except the spinocerebellar. And it makes sense. Why? This is called spinothalamic. Where is the destination? Thalamus. It's called spinothalamic. Thalamus. This is called the posterior column. It's going to the cortex. It will go to the thalamus first and then go to the cortex. So the third order neuron is thalamus. Spinocerebellar. Does the spinocerebellar go to the thalamus first? No. The thalamus is not even in the way. So your third order, in this case, there is no third order. It goes directly to the cerebellar cortex. Are we following or not? Any questions so far? Now there is something called sensory homunculus. Sensory homunculus. What is a sensory homunculus? Sensory homunculus is a map in the primary sensory cortex. A map. And it goes like this. If somebody touch your finger, can you say exactly, can you tell, even if you close your eyes, can you tell exactly where is it coming from? If I touch your thumb, can you say, you are touching my right thumb, specifically? Can you say that? Or you say my upper limb? You can't tell exactly, right? How did you know? All of them, all of these sensations are action potential, right? Electrical signal. So electrical signal traveling and going to the brain. How can the brain tell that this is coming specifically from your right thumb? Or it's coming exactly in the middle of your palm? Don't you tell? Can you tell? Right? How did you know? How did your brain know? Everything is coming to the brain in the form of electrical signal. How can the brain differentiate? The brain is having a map, okay? There is a map that's called the sensory homunculus. So this is your brain. Okay? There is a sensory homunculus that goes like this. This is the cortex. So your lower limbs are here, for example. This is your trunk. This is your upper limb. This is your head. So when you touch something, it will go and reach this part of the map. That's how your brain know where is it coming from. Did you understand that? Okay? This is exactly like if you are in the control of phone service, for example, like the old-fashioned way. So you have a lot of phones. You're sitting down and you're receiving phone calls from everywhere, right? Let's say 911. They receive calls all the time. Can they tell where is it coming from?
Yeah.
Even if you didn't tell them, right? It will come from this part, and they can tell. Or like this is what they do in the military. They have a lot of phones. Each one phone is for a unit. So once the phone rings, even if they don't know who is talking or anything, once the phone number one rings, they know that phone number one is coming from military unit in Arizona, for example. So before you pick up the phone, you know it's coming from Arizona, right? Because you have a map. I know that number one is coming from this, 2, 3, 4. You have a map that's similar to your body inside your cortex, and it will reach this part, and this is how we know where is it coming from, and even the nature and size. So you can know all of that because of the sensory homunculus. Okay, so it looks like this. And look at this. See the size of the hand? How big it is? It's even bigger than the trunk. This is your trunk. Can you compare those? Look at this. See, your hand is bigger than the trunk. Why? Why it's represented that big and that large? Why it's not exactly like your body? Because what do you need to know about your trunk? Nothing much. What do you want to know? Do you do anything with your trunk? What kind of information do you want to analyze and understand about the trunk? There is nothing much, but a lot about your fingers. You touch something, you can actually play piano, you play guitar, you move the fingers. You have a lot of information and a lot of fine touches and fine movements that you need to know about your about your hand. That's why the hand is represented in a large area of the cortex, while the whole trunk is represented in a smaller area, because there is nothing much that you wanted to know about the trunk. What do you want to know about your trunk? Something is touching you, or you're moving. Do you have anything else? Can you play piano with your trunk, for example? Can you do anything special or anything fine? Anything in a special movement or something? Nothing. That's why it's represented this way. And you see the fingers are like really big, because the fingers have a lot of things to do. This is called the sensory homunculus. And as you see the pathway, it goes to the thalamus. In this case, this is a posterior column. It go in the posterior, it enter to the first order is here, go to the posterior column, whether gracilis or cuneatus, depending on upper or lower part, and it goes up all the way to the thalamus, and from the thalamus it will go to the cortex. So your destination here is the cortex, and your third order is the thalamus. Okay, this is the spinothalamic. It ends at the thalamus, but sometimes you let the cortex know. This is the other spinothalamic. Referred pain. What's a referred pain? Referred pain is, I feel pain here. I think we all know, if you feel pain here, is it something in the shoulder, like in this skin? What do you think?
Could be.
In the skin. What's the first thing that comes to your mind? Somebody said it. Stroke, right? This is where you feel the pain of your heart, right? I feel pain here. A pain in the shoulder. I'm not talking about inside, in the skin of the shoulder. For your information, this is either coming from the gallbladder, something wrong happening in the. Yes, it can be the shoulder, the actual shoulder. Yes, yeah. But you think about it that maybe I'm having a problem in my gallbladder and liver. If you feel something like here, in the back, in this skin, most likely this is something coming from the pancreas. Okay? So what is this? Here is what's happening. In the case of the heart, okay, the sensation coming from the heart this is your heart. Okay? And the sensation coming from the heart will travel, go to the spinal cord. It's your brain. So it will go up to the brain. Okay? And this is your shoulder. Left shoulder. Look at this area. Your left shoulder sensation will go like this. Look. Traveling very close to the extent of sometimes even touch. Okay? So when they touch, they go to the cerebral cortex. To the cerebral cortex, the pain is coming from here. Why? Because the actual stimulus is traveling and it irritated the very close nerve that's bringing sensation from the shoulder. So that your brain will be confused. Where is this coming from? And what is the type of pain that you always experience? Do you experience more heart pain or shoulder pain? Shoulder, it's more frequent. How many times did you feel heart pain? Did you ever feel pain in your heart before? But how many times did you feel the shoulder pain? A lot, right? Anything can cause some pain. So to the brain, it's coming. Both of them are coming at the same time. So the brain is always remember that this is coming from the shoulder. So this is how it occurs for the referred pain. And it's not the only one. There are a lot of areas. So anytime the sensory pathway, the sensory nerve coming from skin, very close to the sensory nerve coming from another organ, you can confuse it and the brain will refer it to the most frequent source. So to the brain, it's coming from the heart or from the left shoulder. No, it's coming from the left shoulder. This is what I know. So it's a confusion in the brain. Around the navis, for example, if you have pain in this area specifically, around your umbilicus, if this is an intense pain around the umbilicus, most likely this is appendicitis in the beginning. Okay? I have severe pain exactly, not in the abdomen, not the whole thing, just exactly around the umbilicus. This is appendicitis in the beginning, and later on it will be localized here. So I started the pain here around the umbilicus, and a couple of hours later, it started to go here. This is appendicitis right away. How did I know? Because this area, the sensation from this area around the umbilicus, go to the brain. Sensation from the appendix, go to the brain. And because this is more common, so the brain will say, you're having pain here. It's not. You don't have anything on this skin. It just happened that they are very close together, that they touch each other, so stimulate, so the brain will think it's coming from the brain umbilicus and it's actually coming from the appendicitis, but because when did you receive something from the appendix? So if I wanted to, where is it coming from? I always refer it to this person. This is like, the way I think of it is some of us here are talkative, right? Some of us are talkative. We talk a lot. So if I hear something coming from this area, I say it's you, for example, or you, right? But is it really him? No. him or anybody else, okay? All right? So if I hear something coming from this area, it can be him or her in the back, right? But why did I say, no, it's most likely it's him? Because he's talking, right? So I refer to what I used to hear. I used to hear somebody talking at this area. So I refer to him. Maybe it's not him this time. But excuse me. I'm just joking, okay? So this is about the referred pain, and we will do the rest next time.